Welcome. This episode of Inside the Genome is a recent recording of Myriad Oncology Live, a webinar hosted by me, Dr. Thomas Slavin, Senior Vice President of Medical Affairs at Myriad Oncology. The opinions and views expressed in this recording do not necessarily represent those of Myriad Genetics or its affiliates. To participate in a future recording, please visit Myriad Oncology for a list of dates, times, and subjects. I look forward to exploring the world of genetics with you all. Hello, everyone. Welcome to Myriad Oncology Live. I'm Dr. Thomas Slavin. Thank you for joining today. This is a weekly webinar series. If this is your first time, looks like many people are repeat folks. If this is your first time, it's a live weekly webinar series, and they're theme-based. A little housekeeping is always to start. Last week's was great. Rob, Finch and Lauren Spanza, just did a fantastic job. We had just great discussion, around LGBTQ issues in hereditary cancer, specifically, and how it affects, that community, how we can be more sensitive as providers, when working with that community. And some of it was direct, some of it's even indirect, things like, how to even have test requisitions and materials written. So yeah, great discussion. Today, we're talking about advancements in Lynch syndrome and other colon cancer predisposition syndromes. And next week, we're going to get into HRD. So please join us for that one. That'll be a good discussion. And you see here, we'll come back to tumor germline later in the month. And then kind of getting a little lighter. I didn't build out all of July yet, but June is a little lighter. People start taking vacations here and there. And we had ASCO going on and a few other things. So June's a little on the light side. July, I'll build out once, we kind of get into June or so. And if there's ever a topic that you really want to, have on discussion, please just let me know or Shelly know. And I see Shelly on, thanks. She will help with the chat. So if there's any questions, she can, always feel free to unmute yourself. But if you're not wanting to unmute, definitely send a chat to Shelly. And also just to help everyone, we're recording because we get a lot of requests just to have these available for people that can't unfortunately make these. We're still haven't put any of them up. We're talking through different ways to do it. We may just do it as like a general podcast type format, just so there's some audio if anyone wants to go back through and listen to any of the really good topics. But we did start recording, so even like last week's will be up at some point. And then Shelly may also present a little bit. There was a recent paper that she was a co-author on towards the end today. But without further ado, I'd like to present Dr. Eduardo Villar Sanchez. Thank you for coming on today. Dr. Villar Sanchez is a medical oncologist at MD Anderson, and I've never met you in person, but we had a nice, we did one of the CGA podcasts based on some of your recent research. And then when I thought about this topic, I thought, geez, yeah, you'd be perfect to kind of bring on because, from that podcast, it was very clear that, you're really plugged in to where, prevention of colorectal and other cancers potentially are in Lynch syndrome, whether it's through chemo prevention or, vaccine trials, things like that. So if you want to unmute yourself and maybe tell the audience a little bit about, what you do at MD Anderson, how maybe you got involved in all of this research and, what your current interests are, that'd be fantastic. We can kind of kick off the discussion. And anyone feel free to ask questions throughout. We keep this as a very informal, flexible format.
Awesome. Well, thank you so much, TJ, for inviting me here today. I think this is a great format. So About me, about myself. So I am a medical oncologist by training, as you said very well in the introduction. I am originally from Spain, so I train in medical oncology in Barcelona at that time in Vall d'Hebron University Hospital. So I was one of the earlier trainees of Jose Baselga and Josep Tabernero. And then during residency and had the opportunity, obviously, to be very exposed to research and particularly my focus on that day was more colorectal cancer, but then became very interested on hereditary syndromes, familial cancers, and started to build up a translational research interest in the area. So then after
I saw you did a fellowship, at Michigan. Right?
Well, yeah. So then after that is when I decided, after my residency, decided to spend some time to do a pure postdoc fellowship. And so then I moved to Ann Arbor, Michigan, where I was initially doing just research in the laboratory of Steve Gruber, whom many of you may know, somebody that has been working as well in hereditary cancers for a long time and continues doing so right now at City of Hope. And then after that, Steve was the one that put the bug on whether or not should I consider to stay permanently and develop more my career in the United States. And then I had to subsequently retrain in hematology and oncology at University of Michigan. So overall, I stay in Ann Arbor for almost 5 years between my research time and my clinical fellowship time. And then I moved to MD Anderson Cancer Center in Houston. That was January of 2012, and basically recruited by Powell Brown and Ernie Hawk for the Department of Clinical Cancer Prevention in MD Anderson, where I have stayed since. So this was my first faculty position. So in MD Anderson, the Department of Clinical Cancer Prevention is a very heterogeneous group of individuals, where we have basically one branch that runs our cancer prevention clinic, and we basically do a screening and prevention for breast cancers, colon cancers, melanoma, and whatnot. So part of the department are clinicians that are basically practicing full-time in prevention issues. Then there is a part of the department that basically are PhD scientists that run research labs that are interested in understanding molecular carcinogenesis in general. So, but early initiations, the first steps that lead to the transformation of normal tissues into pre-malignancies. Mm-hmm. And then there is a group of us that are MD, PhDs, physician scientists that we do both, right? So in my case, I continue practicing as a medical oncologist in MD Anderson one day a week, and basically my clinic has evolved. So I continue seeing patients with colorectal cancer, where I provide care from the medical oncology standpoint. But then I am also a faculty in the genetics program, and I do see patients with hereditary syndromes. And basically, what we will do in a clinical cancer genetics clinic. Recommend I work very closely with the talented group of genetic counselors that we have, and discuss issues with genetic testing, and then obviously surveillance after that. My specific focus obviously is more towards GI. There are other groups that do more breast, but basically pancreas, colorectal, stomach is most of what I see. And then obviously within the community on MD Anderson, then naturally many patients that run into, unfortunately, diagnosis of cancer within the context of hereditary syndromes also come to me, and I take care specifically of them. And then the rest of the time is basically running my research program that right now is a little bit spread all over the place. So I have I have a lab where I have a group of wet lab researchers, PhD researchers, and again, we are interested on understanding molecular carcinogenesis from the very initiation point. We have mouse models, but always
So just in
use.
hereditary cancer, or just in
No,
general?
yeah. So
Yeah.
that was what I was going to say. We use hereditary cancers
As a model.
as our model, right? Particularly FAP and Lynch syndrome. I think there are historically they have been exceptional models to understand sporadic carcinogenesis, what I will say more chromosomal instability carcinogenesis, and then mismatch repair deficient carcinogenesis, and then obviously they serve as a model, but at the same time help us to identify targets.
Help all of us, yeah.
And then we push that into another of my hats, which is basically implement clinical trials. And in that regard, we have a very nice collaboration with the Division of Cancer Prevention, the National Cancer Institute, and we are the hub of one of the so-called consortia to develop early phase chemoprevention and immunoprevention clinical trials. So that's where, for example, the work that we published recently with naproxen was generated. And
we'll dig into that in a little bit.
Yeah.
I think.
And then the other thing is there is another part which is more in silico system biology, where from the get-go we were very interested on using next generation sequencing and understand better what is the genomic landscape of normal at risk tissue and pre-malignancy. Kind of funny because when I started to do this back in 2012, people thought that we were a little bit crazy, like, okay, you're going to sequence somatic mutations in normal tissue, but you're going to find nothing there. And that was the feedback that I was getting all the time. And I was like, well, no, these tissues are at risk, so they should be accumulating mutations. So
you're ahead of your time.
Well, I mean, I don't want to. I also don't want to oversell the entire process. I think we always approach these issues from a naive standpoint, and then we realize how complex it is. But I think we at least we took the chance and again naively, but I think we were right, and obviously there has been a lot of subsequent research, not only by us but by many others, and that basically have been hammering on the same issue that there is already somatic genomic variation that you can identify in normal tissues, but then obviously working on pre-malignancy, and we have a very good biobank of samples that we have been collecting over the years from our amazing Lynch syndrome patients, families, and also as well FAP and other genetic syndromes that I'm sure everybody here is very, very well aware. So that's what I have been doing for the past 9 years, and so far it's been a really, really good ride, and enjoying it basically every day. So
yeah, that's great. I mean, you're definitely a full plate kind of person, it sounds. So how many days of clinic are you doing a week?
One day.
Okay.
One day.
So you just kind of alternate between hereditary and general med-onc?
My clinic schedule is kind of funny. My PA probably has has issues sometimes reconciling what we are seeing, but it's basically intercalated. It's seemingly integrated basically, and we have our genetic patients and our oncology patients and through the day. So it's quite interesting. Now, obviously with COVID, things have evolved in a very interesting way, but so part of the clinic is virtual, part of the clinic is in person. Obviously, initial stages of genetic testing and all of that is more virtual. I have to say that we don't do much in person. The in-person visits that happens with the high-risk population are when they have been diagnosed and we need to discuss surveillance and things like that, or
oh, great. And So getting back to the chemo prevention. So yes, you just had a really nice publication in Gut that came out in March, looking at naproxen.
Yep.
The title is Naproxen Chemo Prevention Promotes Immune Activation in Lynch Syndrome, colon mucosa. Let me, I'm going to put the link in the chat actually, so people have it, because it's a very nice article. And that's what we spoke about on the CGA podcast, which I thought was really interesting. And yeah, I mean, I think from my perspective, I was on the NCCN Genetic Familial High Risk Committee. I mean, we've been talking about aspirin for some time. It's still, I think at the moment, off the top of my head, it's now written in as it could be a potential chemo preventative, but I think it says something like the dosing is not quite worked out or something like that, or new trials are going on. And yeah, I just was wondering your perspective. I mean, and where all this is going.
Yeah, I am kind of surprised. Obviously, I am a medical oncologist by training, and so treatment is how we are trained, right? So we are trained to treat people, and obviously I went through the process of transforming myself into a prevention person, right? My boss, Powell Brown, defined it as that they have induced a mutation on me. So I have mutated from a medical oncologist into a prevention oncologist, right? So my bias obviously is towards intervention, I would say, and treat. So I feel comfortable. So to me, it's a little bit shocking that we're not adopting this much more in the field, right? Like, yeah, I understand. I mean, all the theoretical, not concerns, but all the theoretical arguments behind CAP2. Yes, it's a high dose of aspirin. But in reality, I mean, the paper is quite clear on the benefit, right? Yeah, you can argue.
This is the John Byrne study. Yeah.
But you can argue it's a high dose. Sure. But don't we have enough epidemiology and research on one side, which you can argue that is observational, but large studies demonstrating that aspirin, whatever dose you use it, is chemopreventive for many cancers. And then at the same time, we have prospective cardiovascular intervention trials. Now, yes, chemoprevention endpoints were not primary endpoints, but it's a quite fairly structured research that you can trust. I mean, now a purist will come and say, well, but the trial was not designed in that way. All that I am saying is we have an intervention that has been proven by multiple ways to be efficacious. And we know well the agent, we know well the side effects, we know what population to treat, and yet we don't apply it. I don't know. Now you ask me, do you recommend 600 milligrams of aspirin to your Lynch syndrome patients? The answer is no, I don't. I personally don't, and I don't have any problem in saying what I do. I do recommend that they take 300 milligrams. Where did I pull that dose?
325, you mean?
300 or around 300.
Yeah, so because 325 is what you can get in the
325.
US, yeah.
I mean, I tried to say 300 because then my European colleagues then don't reconcile the dose.
For those that you don't know, I mean, we may just do a side on that because so in that trial it was looking at 600 milligrams as the primary dose. But we really can't, in the US, we do 325 tablets. So, to get to 600, you're really going to 650. So it's been actually like a point of problem, but, there's probably not a huge difference between 600 and, 650 at the end of the day.
I think we are talking about minimal comparison, but so 325 is what I would recommend that they do. Now, what points I take into consideration? I look into the age, obviously. Probably my recommendation is less strong when patients are already 60 or older. And that, why is the reasoning for that? Because obviously, in terms of life expectancy and the potential benefit over time, I mean, obviously this goes into carcinogenesis. So you have to treat way ahead of time to then see a potential benefit in the future,
Okay,
right?
never really thought of that. Yeah.
Well, if you think about it,
Yeah, it makes sense.
CAP2, you see the dissociation in the benefit when you are following more than 10 years. So that gives you a little bit of the time horizon, right? So probably it's better if you start recommending this when people are in their 30s, when people are in their 40s, and then basically you are protecting them for the ages where most likely their risk increases more substantially, right? And that's what I do. I also tend to look at comorbidities. You don't want to treat people that have hypertension or uncontrolled hypertension, that have had obviously a past medical history with bleeding, GI bleeding, brain bleeding, things like that. Those are no-brainers where basically you're starting to run into tipping the balance, and the risk-benefit ratio is changing, right? So those are the considerations that I take, and then I obviously always tell them that this has to be done with the approval of the PCP, because I am seeing these patients from a high-risk genetic standpoint. I see them sometimes yearly, sometimes every other year. So that means that you're not directly taking care of all of this, right? So you have to engage the patient, to engage the primary care physician, and get that on board. So that's what I do.
Do you tend to say, I recommend this, but speak with your doctor about it? Kind of thing?
So this is the recommendation. That's what it makes sense. I do think that you will benefit from this. Now we need to collaborate with your primary care physician, because I'm not going to be there all the time, and it's not where the patient is going to run if there is any issue, right? The last person that probably they're going to think about calling it's me, right? That to be quite honest, right? So that's what I tend to do. So that's what, again, it really strikes me when and obviously this is not a criticism of you guys in the NCCN panel, but the adoption is
I'm not on it anymore.
Okay. And I have discussed this with Patrick Lynch, who is one of our
he's on the panel.
Exactly, he's there. So I have already told him many times. So he's our representative.
Yeah, and I think the language did get worked in just recently, like the last year or two, if I remember. But yeah, it's a little soft at the moment. I've also thought over time that like Beta brought up. Beta's an awesome genetic counselor. She used to work with a really fantastic doctor, but now does not anymore at City of Hope. Just kidding. Talking about myself. No, but Beta brought up, what age to start at. And so I think these are the things that still need to be maybe worked out a little bit, because clearly, I think when it gets into guidelines, people want fairly concrete, like, okay, do this now, blah, 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 this dose, all these things. And I feel like that's what still is maybe a little up in the air. And I think people in the know, like clearly yourself, doing a lot of the research and, just see the pros and, cons and can evaluate patients. That's one thing. And then the other thing that I think is causing some delay here, truthfully, is, if you think about the patient population of Lynch syndrome, unaffected patients, or maybe patients that have been treated for a primary colon cancer or endometrial or something, who's really taking care of those people that are in the know? You're in today's era, even if you're going to a Lynch syndrome focused clinic, like, you're running, or, we had at City of Hope, or some of these other major organizations, you're in very good hands. But most people are being seen by, genetic counselors, being diagnosed. They, usually there's not really a substantial follow-up at that time. There's some recommendations. I mean, and then it becomes kind of a scope of practice question sometimes, where it's, if it's not in guidelines, it's really very clearly in guidelines. It makes it tough for the genetic counseling community, who really, isn't, treating people with pharmacology, to then make recommendations to even the primary care doctor at that point.
Yeah, no, I understand. And then obviously That is a really good point, and I do agree as well that. But again, the issue with prevention, chemo prevention, and then hereditary cancer syndromes is that I think we are also very used to a certain level of evidence, and we have to be fairly realistic, right? So, how much evidence are we asking ourselves to have in hand to make a recommendation? And I understand. I mean, the guidelines are written to have a maximum level of evidence, but again, it's going to be very difficult. Like if you were going to wait to answer the question of 300 to the results of the CAP3 study,
right,
we're not going to see that in the next 10 years. So maybe I will be by the end of my professional life when I am capable of writing level A recommendation, right? So I don't know. But people need answers right now. But and again, we're not talking about giving a chemotherapeutic. That's as well one of the things that we now going back to what you are saying is obviously who is taking care of the patients is a very diverse population of professionals, right? With different backgrounds, and I understand. I think also that then at some point as well there is a value on referring patients at least once to high risk clinics that are kind of like maybe more nested in tertiary referral centers like at City of Hope, MD Anderson, or many others in the country, right? Where maybe the patient can come once and get a set of long-lasting recommendations that then they can take to their local providers, and that feeds back as well to many of the things that we see when these patients come. Community gastroenterologists with frequency of colonoscopies and endoscopies as well. There is a lot of not ideal communication in that regard. So I think the value of getting these patients seen at least once and getting a firm set of standards that then they can take later to their local providers is also important there, right? So and in that way, hopefully addressing this point, like, okay, as a genetic counselor, you're supposed to do what you are supposed to do. You may not be comfortable making a therapeutic recommendation, even if it's a chemo prevention recommendation. And in that way, was working with a higher risk clinic can make sense. I don't know.
Yeah. And there's probably ways to clean some of that up. I mean, it could be, consider, aspirin,
right,
based on risk tolerance profile or something of the patient. Yeah, I mean, from a genetic counseling perspective, but yeah, there, it's pushing the limits of, some of the comfort level, and then there's other trials going on, obviously in FAP and I mean, looking at other even more, chemo type drugs like everolimus and some of those that that's not over the counter at that point.
right.
So it'll be interesting, like DMSO. I mean, it'll be interesting to see where all this goes over time, and there may be some rationale, even if the benefit is not huge, to keep it more on the over the counter type of chemo prevention. Not sure.
Well, I think chemo prevention is getting more and more complex, right? And you said everolimus at some point. There are trials with that. Erlotinib now with FAP, DFMO, as you said. So I think things are getting a little bit more sophisticated. Again, I think these patients are going to need to come to a high risk kind of environment at least to get some recommendation and expert advice if we are heading into agents that have toxicity profiles that are a little bit more out of the over the counter kind of thing, right? That could be an issue now, and I think this is going to be something that is going to be growing and growing. I mean, we're running more clinical trials for chemo prevention with more sophisticated agents. We are heading ourselves into immunoprevention. We are heading into vaccines. So I think this is something that we are going to to see developing in the very near future.
Yeah, so I do want to get into that, the vaccines and immunoprevention a little bit. Real quick though, to close out kind of the aspirin discussion and naproxen, which is what your paper was on. So what year? I mean, there's some chat discussion about when would you start age wise. I mean, it sounds like you're starting young, but I don't know if you have in your mind a certain age. And it sounds like you do 300 milligrams, I assume daily, of aspirin, and then why not naproxen? Or where do you think that's going? The other NSAIDs.
Well, I think we are moving hopefully into. I mean, obviously, the trial that we reported is a phase 1 safety. We were trying to get the safety profile when you're doing in a chronic administration, and we were trying to determine the dose, right? So
and this is just for context. This is the naproxen discussion,
right? The naproxen discussion, but the co-clinical trials with animal were clear towards a benefit over aspirin. Now that is not the same to say that naproxen is more efficacious in humans. Obviously, hasn't been tested. Do I think that we are going to see a head-to-head comparison trial?
That's gonna be tough. Yeah.
Don't think so. For practical terms, I don't see that happening, basically.
And why do you think naproxen would work better? I mean, just based on
I think
the type of medicines.
I think it has and that's what we were trying to define, wider net of biological effects, right? I think obviously we have been thinking in naproxen, or we have been thinking in aspirin, naproxen, and even sulindac in FAP as cyclooxygenase modulators, right? I mean, that's what they do canonically. Yeah. They modulate prostaglandin, then they modulate inflammation. I think there is much more into what they do apart from that, right? And that's as well what we were trying to explore in the clinical trial. I do think that naproxen is going to have other benefits hidden there that perhaps aspirin doesn't have that much, or maybe they have a little bit, but not that much. So I think modulation of stem cells is probably something that naproxen does effectively. I'm not saying that aspirin cannot do it, but probably requires different doses of aspirin. I think naproxen also works as an immune stimulant. Again, I think aspirin can do that, but probably naproxen can do it more effectively or efficiently.
And why not Motrin? I mean, were you looking at like ibuprofen and other NSAIDs? Why do you land on naproxen?
Because of the profile of side effects. With again, you tell me why not Motrin? Motrin probably is as effective as naproxen from the pharmacological standpoint and from the potential benefits on how they affect other pathways. But I think the safety profile of naproxen is beneficial in comparison to ibuprofen. I think ibuprofen in that regard has more GI effects that basically pushes a little bit ibuprofen more towards the profile that you have with aspirin, right?
And that's one of the bigger concerns, just for everyone, is for the non clinicians in the audience. It's bleeds, GI bleeds. I mean, you can get ulcers. I mean, it can cause these medicines, if taken daily, chronically. I mean, you can get some major problems from them. So you do have to be pretty careful.
Yeah, and that's something that, for example, I highlight to my patients, even when I am recommending aspirin. It's like, okay, you can get a stomach upset. It wouldn't make it would be prudent then, if you are nearing that point, to get your PPI or proton pump inhibitor and basically make it more tolerable. But again, I think aspirin and ibuprofen tend to do more of that.
Yeah. Have you had any major complications from any of your patients? I did hear Mike Hall said one of his patients one time had a pretty good GI bleed that had to get fixed.
And that's something that is consistent, and that's something that is seen, right? So we have to take that into account. No, I personally haven't seen any any trouble, particularly with my patients. And so, but yeah, acknowledging that can happen. That's a typical question that obviously John Byrne runs into every single presentation that I have seen him giving. Obviously, our colleagues in Europe are much more into cost and cost efficiency for their healthcare system. So that they always get into that point when they talk about that, right? So how many you need to treat to see a complication and all of that. I mean, I think conversation in US is a little bit more different, right? We probably are more focused on that individual patients. Not that they are not, but I mean the perspective is different. I think they approach the conversation from a systems point of view. Rather than an individual practice point of view.
Well, let's get into the vaccines a little bit, because I think that's incredibly interesting. So what
TJ, can I ask one question?
Yes.
Sorry. I'm curious, in addition to the NSAIDs, do you have any line of sight of other biologics or things that would target the immune system in Lynch syndrome patients?
So we have been, well, I mean, it's a really, really good question. And one of the things that I tried to articulate at some point, or at least introduce in the conversation, was the use of checkpoint inhibitors, for example, right? I am talking about mostly drug development, right? And it was received with a lot of resistance. Obviously,
for chemo prevention, you're saying?
For the chemo prevention, obviously, in therapy is well established.
Right.
Stage 4 and even unresectable. In that regard, we, for example, have a clinical trial in MD Anderson for MSI high patients, where I have recruited many of my Lynch syndrome patients that have borderline resectable and locally advanced tumors, where we have seen incredible benefit. The data is going to be presented in ASCO. This is a clinical trial, and also in ESMO GI, and it is quite astonishing. I have even seen endoluminal complete response of tumors, like when you repeat colonoscopy and it's gone. But well, so but we were talking about,
just for other people online. I mean, a lot of that is just thought that it's, essentially going down the mismatch repair pathway, TMB, MSI. I mean, those are the kind of tumors that really respond well to the checkpoint inhibitors in general, like immune therapy.
And I have right now, for example, a patient in the trial that is benefiting spectacularly. We haven't even breached the conversation of doing surgery, because the tumor is radiographically gone. And we are talking about a young gentleman that had a mass in the transverse colon that was actually involving even the stomach. So it's quite nice. But again, going back to chemo prevention, the conversation shifts, because now we're talking about a healthy person, or at least a cancer survivor that has no evidence of disease, and we're talking about using agents that can induce immune thyroiditis, immune hypophysitis, a pattern of inflammatory bowel disease like. So we were not able to articulate a clinical trial, at least using funding from the NCI, because the perception of the risk of potential secondary effects was too high, right?
Yeah, and it's similar in my mind of using PARP inhibitors in like a BRCA1 or 2 patient for chemo prevention. I mean, you do have a lot of hematologic side effects, other things that it's hard to take a medicine like that sometimes and move it into like you're saying, a healthy person that really doesn't have any problems. Not to say that won't happen, and maybe at very low doses it would actually work really well. I don't know.
Yeah, and so then I think the problem is then the pushback has been quite important, and we have missed the opportunity to discuss what should be the dose. Now, the drug developers then bring up the point that at least the generation of checkpoint inhibitors that we have, the side effects do not follow a clear dose response pattern, but I think obviously there is not that many patients that have been treated with low doses. So
Right. Yeah.
I think at some point we're going to have to bridge that gap, and I hope that can happen at some point. There was a clinical trial for Lynch syndrome patients that Ohio State was able to articulate with Nivo, and it was closed. So
due to
it
side
didn't.
effects.
Not clear to me. I was not involved. I was not involved in the clinical trial, and but it was. I think it was closed after 3 patients. I don't have. So the informal rumors is that it was not due to side effects. That maybe was more industry type of decision. But nonetheless, we're not going to learn any. Unfortunately, we're not going to be able to learn anything from that. So the response obviously is that I would love to see other agents. I hope that subsequent development of future immune checkpoints that hopefully may have less of a side effects, or maybe that we can revisit the issue of using them at the lower doses. I do think that it's a very important question in the field. Which brings then to the point that TJ was heading into, is then vaccines, because obviously if immune modulation, we have been pushed away from checkpoint inhibitors, I think then is when the field has tried to embrace more immune manipulation towards vaccines, which is kind of like a little bit more accepted. And now in COVID times, even much more accepted, because we are all thinking in vaccination all the time, right? So we have all of the sudden, all of us
advanced our vaccines, and especially, I mean, you know, what people sometimes, I think hasn't hit us yet. What we just did with all these vaccine rollouts is, you know, we really created a whole new class of vaccines with the RNA vaccines, and you know, even the adenoviral vectors. I mean, just understanding a lot more. So I think we really advanced our vaccine knowledge as a whole, probably by 10, 20 years. So I don't expect, you know, just because, you know, we get a handle on COVID at some point, or we're pumping out now adequate vaccine or tweaking it or whatever, that, you know, all of a sudden we're just going to stop, you know, advancing the science, because, you know, we essentially cured a common version of a cold. You know, not to downplay cold, but, you know, coronavirus is a major, you know, general cold virus. So the fact that we were able to even, you know, create a vaccine to, you know, squelch it to a good extent is pretty amazing. And then you think about like, okay, now what can we do with this? And, you know, the reason these companies were already kind of in progress was because there was so much anticipation around this technology and how you can use it, and you know, even just the RNA side around cancer and everything. So
yeah, absolutely. So somebody put it in the chat, a case report from the oncology from in the journal Oncologist. There is another one that I'm going to put in the journal Cancer Prevention Research, and it's a similar concept. Basically, patients with Lynch syndrome that incidentally have been receiving checkpoint inhibition for other reasons. This case report is particularly interesting because you see the modulation of skin neoplasm over time in this patient when was treated with checkpoint inhibition. So that speaks to the fact that you can prevent basically pre-malignancy and cancer using checkpoint inhibition.
That's great.
So, and I think we are going to see that popping up more and more and more, because obviously there is going to be patients that are receiving treatment and with these checkpoint inhibitors for other
and maybe cases, you know,
so.
Just thinking out loud, I mean, you know, CMMRD, congenital mismatch repair deficiency syndrome, I mean, that's been so impressive on the checkpoint inhibitor side that you know, and it is a very serious disorder with an extremely high cancer burden. I could potentially see chemo prevention starting there, but the problem is these are just rare diseases. It's hard to get cohorts together, hard to get funding for trials. Oh,
it's very difficult. I can tell you I mean, again, the privilege that I have is that I am sitting in an institution that gets a referral of very complicated and interesting cases. But my experience, I have had a young gentleman with CMMRD, secondary to biallelic mutation in PMS2, and this young guy was receiving treatment for a brain tumor, which is very typical in CMMRD, and at the same time presented with polyposis, and we have seen modulation of the polyposis, coincidentally with being
interesting. Yeah.
with giving
so yeah, maybe
giving
that's
treatment.
how some of this
So,
will come about, is just some secondary effects. Yeah, that you're seeing.
but what you are saying is true. Articulating a clinical trial in this context is so difficult.
Yeah, it's probably never gonna happen.
Because right, so getting these patients, it's very, very, very. I mean,
it could
doing a
potentially
clinical
through the
trial.
international network or something, but
Correct.
yeah, it's very challenging. Yeah, and a lot of times, unfortunately, yes. I mean, when people are identified with CMMRD, they're already affected with some type of cancer.
Correct.
Often, because it's usually coming from PMS2 and MSH6, which isn't the most expressive in the heterozygote state through families, and so the families sometimes aren't overt, but then some child or something is born and they just have tons of cancer burden.
Exactly. I mean, patient that we were discussing in particular, obviously, is a PMS2 carrier. Parents are the Lynch syndrome carriers, right? Known after the fact, and they never run into any cancer issue, right? So.
Yeah, it's amazing. So what's the vaccines? I mean, we have about 10 minutes left, so I definitely want to touch base here. So where are those at right now in your mind?
I think obviously there is a group in Germany that has been working on this for decades, and they run the initial clinical trial that has been published recently in Clinical Cancer Research, although it was executed a long time ago, the so-called Mycorrix trial that Matthias Klor I believe is the first author of that publication, and tested the administration of 3 peptides. Those are based on the assumption that these peptides are frameshift peptides, then therefore these peptides are not present in normal tissue, and that these are recurrent peptides that emerge because, as we know, microsatellite instability tends to accumulate in recurrent loci across the genome, right? So they vaccinated a population of MSI high patients with these 3 peptides, and then they saw an increase in immunogenicity.
And so these are peptides that are being, I guess I'm still trying to get my head around it. So they're peptides that are just of specific genes that are.
I think it's in the publication. I can find it and put it in the chat box. But
are they related to the MMR pathway? Is that?
No.
Okay.
One, if I don't recall wrongly, these 3 peptides. One is TGF beta. It's a TGF beta receptor 2. So it's a frameshift mutation that is going to impact in the coding region of TGF beta. I think the other one is called HT001.
But why do you get these from the just having problems with mismatch repair? Is it just kind of a common?
Right. Yeah. So there has been as well very nice bioinformatic analysis performed by Colin Pritchard and Jay Schender, where they were basically leveraging, for example, data from the TCGA, right? And looking into the MSI and basically trying to pinpoint if there are loci, microsatellite loci across the genome that are more susceptible to accumulate coding mutations. And you can even see a specificity at the level of tissue. So the recurrent coding microsatellites that are going to accumulate microsatellite instability in the colon are different from the endometrium and are different from the urothelium. But there is a shared recurrency among the MSI high tumors, basically. So the same thought is applied to Lynch syndrome carriers. that the deficient mismatch repair system is going to basically induce recurrency in these specific prone sites. And therefore, vaccinating you for that is going to protect you over potential neoplasia that is going to emerge at some point.
Yeah. It's interesting, though, to me that the proteins don't get rapidly broken down, that you can actually target them, because usually you'd have nonsense mediated decay or something going on, and you just wouldn't have much to target from a vaccine, I would think.
That is one of the issues, immunoediting, right? So you have these frame-shift peptides. Part of those are naturally cleaned up by our non-mediated decay system, but there are some, again, that they are more prone to stay. And this is the concept behind the vaccine. In an essence, you have to equate it to a virus, right? With the distinction that the virus is there, is foreign, and it has those fixed proteins there. In some sense, the tumor is also foreign to you, right? In the sense that that mismatch repair system is broken, and it's emerging those neoantigens that are not native to your genome. And that is what you want to make your immune system able to recognize. So the immune system can clear out the lesion when it's very early stages, basically.
Yeah. No, really interesting. I mean, it's going to be exciting to see where all this goes over time. Yeah.
Obviously, from a statistical standpoint, makes sense then to vaccinate with vaccines that kind of like offer more broader recognition in terms of neoantigens.
Yeah.
I mean, there are different schools of thinking, right? Broader vaccines that cover many neoantigens, or maybe more specific vaccines that have the concept that, okay, it doesn't matter, we just want to go after that neoantigen that is highly recurrent and is going to induce high immunogenicity. So if we can recognize at least one neoantigen and clear out the lesion through that neoantigen, it's all that it takes, right?
Yeah. No, very, very interesting. And and then we'll see, gene editing is going to be coming along. And again, with the vaccine advancements that we just made with our pandemic, I mean, I think, there's a lot of opportunity there. I mean, just replacing
absolutely
mismatch repair proteins, not the protein, but the RNA, and then, making proteins and things. Yeah,
absolutely. Now that we are also used to receive RNA-based vaccines, the question is, what about an RNA-based vaccine? Now, we don't even need to inject with adenovirus or peptides. Why don't we go to RNA, right? So I think I think the pandemic, for better or worse, is bringing up an entirely brave new world for us that may benefit patients with Lynch syndrome in particular.
So, all kinds of hereditary conditions. So no, this is great.
As well.
Yeah, well, so we have 5 minutes left. I don't know if there's any questions out there. Let's take a quick pause. If anyone has any questions, feel free to chime in. I know we've been filtering some through the chat here and there.
I don't have any questions that have been sent directly to me, but encourage people to unmute and ask them live.
Yeah, feel free. Give it a second. We'll make it an awkward silence. That way someone has to chime in.
Yeah.
No. And then,
let me see if I can.
Shelley, there was a recent paper just to put on people's radar, since we're on the topic of Lynch syndrome, that I asked Shelley just to show, and she can post it real quick in the chat, which is great. Do you want to give people a really quick rundown, Shelley? Yeah, the Rachel Perlman study, if people haven't seen it.
Yeah, I know I personally could listen to Dr. Villar Sanchez all day because he has a lot of interesting things to share with us. But the first thing we need to do is identify patients who have Lynch syndrome and how is the best way to go about doing that. And Ohio State, as everybody knows on this call, are leaders in this field. And do you recall Rachel Perlman had a paper out describing their Ohio in 2017, describing the whole state of screening patients. And they in that paper, they described the 450 patients that were less than 50. The recent paper that I just posted looked at the entire population, and what they came out with 3 major recommendations, and then their overriding conclusion is that about, at a minimum, a 7.1% of patients with colorectal cancer have a pathogenic mutation that is actionable, which is right in
hereditary.
line.
Yeah.
Hereditary, yes.
Yeah.
And that's right in line with the numbers that we see for pancreatic cancer, where all pancreatic patients get tested, as well as metastatic prostate cancer. So it's pretty significant. Hopefully this group will push that forward. So maybe some guidelines will change and make testing a bit easier.
And also what jumps out to me in that paper is, if you just look at IHC and MSI by tumor testing, it misses a substantial amount. I thought it was like 4.6% or something. I can't remember off the top of my head.
Despite the MSI being more sensitive than the IHC in this group, the MSI failed much more often, 14% compared to 0.3%. And so they recommend the IHC because, for all the variety of reasons we know, you can target into the gene, less tumor used. But they really drove home the point that 1.7% is probably an underestimate. It's probably much higher due to the prevalence of pathogenic variants, due to some of the implications. And if you solely rely on tumor screening, you're going to miss a substantial number of patients. Pretty exciting.
Big advance in the field. So we'll see how all this kind of comes together. So thank you for sharing that, Shelley. And I know we're at time. I appreciate everyone being on, and thank you so much, Dr. Villar-Sanchez. I mean, it's just really amazing to see, to get someone like you on here and just, go through the expertise that you have on the research side and just give people perspective of where the field's going when it comes to the chemopreventative opportunities, how you're implementing it in practice is fantastic. I mean, then, and where, the potential for vaccines may come in, and a lot of hope for patients with Lynch syndrome. And then, I agree, Shelley. I mean, ending on, now how do we identify people? So it's really that we have to pair that together, and hopefully we can keep identifying more and more people, and then have those people in a better setup for true prevention of some type. So thank you so much for coming on. I really appreciate it. You're a fantastic guest.
Thank you for the invitation, and very, very interesting moment that we are all living. And this type of initiative, I think, is great, and to have the opportunity to chat with all of you and share experience and knowledge. So anybody, please do not hesitate if you guys have any questions or anything, just to shoot me a quick email. I think my email is widely available through a Google search, but if not, it's evillar@mdanderson.org. It's pretty straightforward. So, but thank you for the invitation. PJ.
Thank you. No, this is fantastic, and hopefully we figure out chemo prevention before you retire.
Right. Hopefully. We have still some years.
I know. Thank you again.
Thank you, guys.
Thank you.
Bye.
Thanks,
Shelley. Bye.